Women's Health Review, second part. Let's talk about obstetric problems. So, the maternal mortality in the U.S., it's preventable. Every pregnancy related to death, of course, it's a tragic situation, especially when we know that 80% of the pregnancies related death in the U.S. have preventable situations. So, if we can recognize urgent maternal warnings due to medical conditions of the patients, like, for example, preeclampsia, eclampsia, HELP syndrome, or gestational diabetes with predisposed at the same time for preeclampsia, or uh, chronic hypertensive patient, or a kidney disorder pregnant patient, and we provide timely treatment, we can also develop a high quality care for that patient and prevent many of those pregnancy related deaths. There is racial disparities. Black African American have 3 times more likely to die than white women. And there are multiple factors that contribute to this disparity, such as variation in the quality of healthcare, also chronic conditions that ethnicity has, high risk for some of the conditions, but also implicit bias and structural racism. Gestational trophoblastic disease pathology. I would like you to know the karyotype of a complete mole. If you have a karyotype 46XX, it's going to be a completely paternal origin versus of an impartial molar with it's a triploid karyotype 66XXX or XXY or XYY, meaning that you have a maternal and paternal origin at the same time. Remember that when you have a gestational trophoblastic disease, usually you have very high human chorionic hormone. Those levels do not relate with the weeks of gestational age. 50% of the cases that develops into a spontaneous abortion outcome, they are believed to be chromosomal abnormalities. We have risk factors related with spontaneous abortion, which is advance of the maternal age, or the develop of very early vaginal infections or cervicitis, or systemic infections like syphilis or malaria. Also, the exposure to environmental poisoning like lead or solvents or abnormality structures in within the uterine or any genital, especially uterus, like leiomyoma or intrauterine adhesions or congenital abnormalities like double uterus, etc. We're going to talk about preterm labor and preterm birth. When we have regular uterine contractions that can lead to a change in dilation or enfastment prior to 37 weeks of gestation, that is a preterm labor. The pathophysiology starts with the etiology. Whatever the first primary pathway it goes or initiates, like stress, infection, decidual hemorrhage, or uterine overdistension, it will follow a common pathway, final common pathway, to initiate a preterm labor, which is elevation of prostaglandin secretion, degradation of the fetal membranes, initiation of the contractions by the elevation of oxytocin levels. So preterm birth is the birth between 20 and 37 weeks. Preterm labor etiologies can be done by placenta previa, abruption, uh, maybe incompetent cervix, or premature rupture of membranes. Placenta previa usually is the location of the placenta over the internal os. We have also low laying of the placenta, but for placenta previa, we can have a complete placenta previa or partial placenta previa. Risk factors for placenta previa is advanced age, multiparity, smoking, use of substance abuse, history of prior placenta previa, abruption pathology. We can have a partial or complete abruption. It's going to have consequences for the mother and for the fetus. It starts when a maternal vessel starts bleeding, and it will tear away the placenta from the lining of the endometrium, and that will the blood, the hematoma will accumulate, and the baby will start having hypoxia. Incompetent cervix, also one of the etiologies for preterm birth, starts when we have an abnormal sequence of deactivation of the cervix, meaning that we start with uterine contractions or decidual activation prior to cervical remodeling that should occur at the beginning in ripening. So the order of the steps is not normal. When we have a premature rupture of membrane and the baby is interim, that means after 37 weeks, is what we call premature rupture of membrane or PROM. If that occurs before that date, week of gestation, between 24 and 36 week, is called preterm PROM, and before 24 week, it's a pre-viable PROM. The most common PROM rupture occurs after 37 weeks of gestation. The etiology, sometimes we don't have an obvious etiology. We don't know what happened. The other is having risk factors for preterm premature rupture or pre-PROM risk factors, or in intra-amniotic infection, usually is one of the most important causes for pre-PROM, or weakening, physiological weakening because of the forces of the uterine contractions. So the risk factors for pre-PROM is going to be second and third vaginal bleeding, short cervical length, the use of substance abuse, drugs or smoking, low body mass, low socioeconomic status, nutritional deficiency for copper or ascorbic acid, and uterine distension because of polydramnios or multiple gestation. The imbalance between the matrix protease and the inhibitors of those protease is going to be part of the pathophysiology and also the pathological events that will disrupt the membrane, starting with an infection, inflammation, mechanical stress, or bleeding. Normal labor is characterized by 7 cardinal movements of the fetal, which descends through the birth canal, starting with the pelvic inlet by engagement, then descent, flexion, internal rotation, extension, external rotation, and expulsion. And the descending can be measured by the different stations, being the most important station, station 0, which is located in between the two iliac spines. That ischial spine diameter, it's around 9.5. It's one of the most important ultrasound measures that we need to take into account, because the vertex presentation, which needs to go in there. It's exactly 9.5. So it's going to go, but it's very, very stretched. If the mother has a pelvic inlet between the spines, the diameter less than 9.5, we have a cephalopelvic disproportion. That's going to be one of the first stage abnormalities. This is indicating just the biparietal diameter of the baby in the pelvic inlet. Labor pathology, first, second, and third stage. First stage begins in the onset of regular uterine contractions. That will cause cervical changes. It ends with the full dilation of 10 centimeters of the cervix. Second stage begins with the full dilation of the cervix and ends with the delivery of the fetus. The third stage begins immediately after the delivery of the fetus and ends with the delivery of the placenta. Abnormalities of the first stage has to do or with the passenger, who is the baby, or with the power, who are the contractions, or with the pelvics, that's a cephalopelvic disproportion. So for inadequate power of contractions, in the case of the power, or passenger, abnormal presentation, breech, face of bro, abnormal position, occipital posterior, occipital transverse, or an intolerance from the baby for the contractions, or multiple gestation. Has to do with the passenger. So here we have cephalic malpresentations or military, bro, and face. Abnormal breech presentation or frank. Complete one single footling breech or double footling breech. Abnormalities of the second stage has to do, we need to take into account if the patient is the first time who is in labor and with or without epidural, or if it's the second multiparous. So depending on the time, we can define if we have a protracted second stage duration outside the normal parameters, or we have an arrest second stage with no descendant more than 2 hours, or one of the most important is shoulder dystocia. Abnormalities of the third stage are prolonged more than 30 minutes. Abnormal placentation, like for example, placenta accreta, can be also part of the postpartum hemorrhage etiologies, or maybe the placenta separated, but due to a rapid contraction of the lower segment, it got trapped inside. Retained placenta, there are three main types of retained placenta. Placenta adherens, when there is failing contractions of the myometrium. Behind the placenta, we got a trapped placenta. We already talked about that. Or we have a partial accreta placenta. Thank you.